The comparators would be no taper, different opioid discontinuation or tapering strategies, no comparison. So there are various things that we could have as comparators or have all. What we have asked to look for outcomes would be successful discontinuation, dose reduction, self-reported pain, quality of life, function, mortality. This would include accidental overdoses, suicide, any other causes of mortality, as well as adverse events like overdoses. So that's the PICO. Any input on that? Do you want to see any other interventions, any other outcomes as a population right? Yeah.
If would it at all possible to see if there are other systems or constructs that are adding not just to taper, but based off of the empowerment study, the Empower study, if you look at SUD in general, nobody goes into opioid treatment without a myriad of support. And I think that we might want to look at other supports in the tapering process.
So what supports or what systems in place help predict successful tapering?
Yes.
Okay.
And that's built into key question 1E. So if we go through the key questions, we can highlight that. But under key question 1, which is what is the effectiveness for the effectiveness and harms of various strategies? And do they vary by? And tapering supports. And it says, e.g., behavioral interventions or additional therapeutic modalities. So we thought that was really critical because obviously that would be a key strategy within this intervention.
Okay, so I'm not hearing any questions about the population, any other comparators that you all want or outcomes? Okay.
This is a question for the pharmacists, maybe, or physicians. Would it be useful to look at whether the patient was then also put onto another medication versus tapered, which is just tapered?
So like Suboxone or
Lyrica, or non-opioid.
Yeah. We could specify that in other supports, that would be one of them.
Yeah, let's add that.
Other medication?
Yeah. Great.
Okay.
Ariel?
Mm-hmm.
So under the outcome measures, I just assume that everything on that list is self-reported with the exception of the last two bullet points, not just self-reported pain, but self-reported quality of life, self-reported function. Am I correct about that? Those would be surveys?
Yes, they would be validated tools that would measure, but it would be patient responses to those validated tools.
Good, thanks.
I have another one. Is it possible to also call out among therapeutic modalities, to Dr. Kakaro's point, whether the patient received pain education, what their understanding is of pain?
So patient education as one
additional
modality.
therapeutic modalities, including pain education.
We can
Just
suggest
call that out. Yeah.
So it sounds like you all want called out pain education, other medication supports, and then any other systems in place. Any other feedback on the PICOs?
So I just want to highlight that the question 1D is whether tapering or discontinuation is voluntary, i.e. patient decision, or involuntary, i.e. the decision of someone other than the patient. Mm-hmm. And so really understanding where the literature is on this particular question is critical, I think.
Yeah, so moving on to the key question, thanks, Kat. So basically what we're asking is what's the evidence of effectiveness and harms of various strategies for tapering or discontinuing opioids among patients with chronic non-cancer pain, and do the effectiveness or harm of these strategies vary by the medication type or dosage, the morphine milligram equivalents, population characteristics, whether the tapering or discontinuation was a patient decision or a decision by the health system, the provider, or other outside actors. What supports were given, and we can add in the other ones that you specified about patient education and other supports. And then speed of the tapering were the ones. Anything in that key question that you all feel should be changed or added to or clarified?
So in a previous meeting, we talked a little bit about different diagnoses, and our original work in this committee was not to talk about opioids for rheumatoid arthritis or a number of conditions that are already covered benefits on the Oregon Health Plan. And one of the difficulties we ran into is that by and large the literature doesn't tease out very well by diagnosis. Should we ask them to see if there's any update on that, or is that immaterial to the discussion?
So I think that's critical to the discussion. So we tried to build that into the key question 1C, where we talked about the population characteristics, where diagnosis is one of them.
Thank you,
so yeah,
sorry.
I think that that's a critical point.
One other thing, and I don't know if it would be appropriate or germane, but do we want to see, prior to tapering, what other medications people are on to see what effect that might be having? Is that on there?
It was medication type.
Yeah, it's not specifically called out. We could add that to the population characteristics and say concurrent medication use right after comorbidity, perhaps.
I think that co-prescription of benzodiazepines may be an important thing to add in the population characteristics, because in my clinical experience that does make tapering more challenging, and I think that the population characteristics of folks that are co-prescribed benzodiazepines and opioids might be different.
And the other population that rises to my mind is those using marijuana. Across parts of Oregon, there was a significant initiative to restrict those using both marijuana and opioids for chronic pain, where people, for example, had to choose between one or the other. And so if we have any evidence on how this differentially impacts, and that seems like that would be useful to look at as well.
I suspect, given the dearth of literature in marijuana in general, that might be difficult to tease out.
But I think that drove a lot of opioid discontinuation. It certainly did in my clinical practice. So.
Yeah, just to clarify, what you're saying, Mr. Is to clarify those people who were who were asked to make a choice and therefore tapered because they wanted to continue with cannabinoids instead of opioids. Is that what you're saying?
I mean, if that exists. So again, we're looking at what's been studied, and so if that's never been studied, we're not going to have any information on it.
Yeah.
But I know that was a significant community effort that happened across a lot of community centers in Oregon, and so understanding if any type of study has existed that looked at that kind of intervention, that would be valuable. But we may not have any evidence.
And the reason I'm asking for the clarification is because another question exists about the degree to which there is harm to patients who use cannabinoids and take opioids. If I understand correctly, there's a lot of discussion in this state, and yet I don't know that there's a lot of accurate information.
Right. So I would just propose that if that evidence is findable, that we look at it.
Yeah.
So I'm happy to forward you the evidence around cannabinoids if that would be helpful, but basically it's a slew of cross-sectional studies, one prospective study that's very exciting, but it's not controlled, and then one RCT that's underway right now.
So there isn't going to be evidence on it.
Not at that top of the pyramid, not that evidence.
So I think what's also important for everyone to know is that there is going to be very direct evidence as to what exactly this type of policy does, because for the back pain policy, which is implemented by the HERC July 1 of 2016, there are now 2 nationally funded studies that are looking at the impact of this policy that we are now 2 years into. And so, well, hopefully people heard the first part of it because it was kind of important. But the net result is we are going to have directly applicable evidence of the impacts of the policy that HERC made 2 years ago that shows what happens when you make this policy lever decision and what happens to the population over time. So we will have this data in the near future.
There's one other study, not as directly relatable, but Dr. Krebs, who did the space study, she part of the study was that anyone who was on the opioids was mandated to taper off their opioids at the end, and they've been studying that population. And so she just, personal communication with her, they're going to publish that. However soon it goes through all the literature, whatever. But just as a personal communication from her, they had no poor outcomes from that, but it was a controlled environment with a controlled population. And that's personal communication, it's not published.
I don't know if this exists anywhere, but in our clinical programming, we find that people that are tapering either voluntarily or not, if their home life situation is such that doesn't support that process, the likelihood of that being a successful taper is negligible at best. And I'm wondering if we could tease out pre and post, do we have other people either using prescribed opioids or using non-prescribed opioids in the living situation of that person? What's its effect on outcome?
I think we can ask for some population, like some of their background information, but I don't think it's going to be possible to really tease out the details of their living situation. It will just be more gross, like income level perhaps, or disability level, or education, which may or may not relate to that question.
So I have a request for the audience who may not be used to hearing about discussions about the development of studies like this. If you could just reiterate what the hoped outcome will be in non-jargony language of this work.
So what we are hoping is to find the best evidence out there of what happens when patients are tapered off, what their outcomes are, and then if there are information that we can find about best supports or best ways or etc.
From existing studies.
It would all be from existing studies. Now, I just want to be a timekeeper. We had told the public that they would be able to have testimony starting about 5 minutes ago. We have one other item, which is we're going to be surveying the CCOs about specific details. I want to ask you all about that, but I want to be cognizant of our agenda. So I'm going to switch this over to public testimony, and then we'll have half an hour, and then at the last 10 minutes, I want to make sure we touch on that survey, and then we're going to definitely want the task force to give staff some direction. So if you have any other input or anything on the PICO and key questions, et cetera, hold those until those last 10 minutes.
And so I've got 16 folks here that have signed up to testify. Is there anybody that didn't get their name on the sheet that wanted to testify?
And for those of you who are not familiar with our process, what we will do is we ask that 3 folks, Darren will call up 3 names. There's the table there with the 3 chairs. If you could state your name and any organization you represent, and if you don't, that's fine, you can represent yourself, and then any conflicts of interest. And the conflicts of interest would be mainly financial. So if you have ties to a specific pharmaceutical company, for example, it's not whether you are a patient or a provider, et cetera.
And so with 30 minutes and 16 people, we're going to have enough time to allow 1.5 minutes per person to allow for, introducing yourselves and stating conflicts of interest and transition time getting up to the table, which isn't counted against you. So I'll call up the first 3 names. Oh, and I'll have some time cards with 1 minute left and 30 seconds in time so you can know where you're at in your testimony. So if I could have the first 3 people come to the table, Diane Weaver, Kate Nicholson, and Dr. Richard Lauhern.
Can I ask a quick clarifying question while they're coming to the table? Just to clarify, I think that our original body of work was to consider whether to add a benefit for something that is not currently covered.
Right.
And I think that a public understanding is that the goal was to take away benefits that might already exist. So really our work is thinking about adding a benefit that is not currently present, and then to consider the potential unforeseen consequences of adding that benefit. Is that still our body of work?
Right, so currently the diagnoses we're considering are not covered, so there's no access to physical therapy, to You may have access to cognitive behavioral therapy if you have depression or anxiety or another diagnosis, but not specifically for these. And also technically no access to medications, and I know some CCOs have actually been applying that. So if this is a below the line condition, you don't have access to any medications regardless of what this group says. Thank you.
Okay, Diane Weaver.
Good morning. My name is Diane Weaver, and I'm on the Health Policy and Health Economics team in Avanos. Avanos is a manufacturer of a medical device company. I have no conflict of interest to be here other than representing a non-opioid treatment for chronic back pain. Back pain for both the facet joint and the hip and the knee. Basically how it works is it is a medical device that is for cooled radio frequency, and this particular medical device takes less than 45 minutes in the OR. It basically denervates the nerve or ablates the nerve, and it interrupts the pain signal from the nerve to the brain. We have many randomized control trials. There's a systematic review in the packet that Jason is actually handing out right now. One of the things that I really want to talk to you about very quickly is that it's cooled thermal radio frequency. It is not cryoablation, it's not pulsed, and it's not low thermal. It denervates the nerve equal to or greater than 80 degrees Celsius. This is the first and only FDA cleared product for denervating the nerve and chronic nerve pain lasting up to 24 months. So there's a new study, randomized control study by Davis, showing that there is chronic nerve pain relief up to 24 months. I'm sorry, did you say time?
30 seconds.
Oh, I'm sorry. Okay, so I really wanted everybody to know that what Avanos does is we put together cadaver labs, both here within Portland, Oregon area, as well as Seattle. We welcome you to come to a cadaver lab. We solicit physicians that would like to understand proper patient selection and proper medical technique. Thank you very much for your time.
Thank you. Kate Nicholson.
I'm reading on behalf of Kate Nicholson. This is a 3-minute, I think about 3 minutes, so just let me know if I'm going over. Kate Nicholson is a civil rights attorney and a nationally recognized expert on disability law who serves as a lawyer and manager in the Department of Justice Civil Rights Division for 20 years. Patients deserve safe, effective choices to relieve pain, not just a pill. So begins a letter from Patrick Allen of the Oregon Health Authority in the Wall Street Journal in response to the August 17th opinion piece, Oregon Overshoots on Opioids, by addiction experts Sally Satel and Stefan Cortez. Absolutely. The problem with Oregon's proposal is not the expansion of choices, but the elimination of them. Oregon proposes to deny Medicaid coverages of prescription opioids to most chronic pain patients after 90 days. As I and a number of pain and addiction experts explained, in a comment of the proposal submitted on August 7th, 2018, it does so in contraveningly of every federal and professional guideline on opioid prescribing, including that issued by the Center for Disease Control and Prevention in 2016. I personally experienced severe intractable pain after a surgical accident left me unable to sit, stand, or walk for almost 20 years. Appropriate pain treatment that for a time included opioids enabled me to continue work as a high-level civil rights attorney for the Department of Justice despite my physical limitations. The CDC just issued an updated report on the prevalence of chronic pain and found that of the 50 million Americans who suffer from chronic pain, almost 20 million have debilitating pain that limits major life activities like mine. Undoubtedly, some of these people live in Oregon.
Sorry. Could you provide that to Jason and we'll be sure to circulate it?
Hi there. I'm Evelyn Blackburn with the Oregon Pain Action Group, and I'll be reading for Richard Lawhorn. He's a doctor, or director of research at the Alliance for the Treatment of Intractable Pain. He says, as I noted in May before this group, the CDC data shows us that there is very little relationship between rates of opioid prescribing by doctors versus opioid-related overdose mortality. Today, I offer further insight on the demographics of chronic pain, addiction, and opioid mortality. If medical prescribing contributes substantially to opioid mortality, then we should expect to see higher mortality in groups prescribed opioids most often, but we don't. People over 50 are prescribed opioids 250% more often than young adults, but over the past 17 years, mortality has skyrocketed in youth, while remaining stable among seniors at the lowest level for any age group. Patients who benefited the most from liberalized prescription policies before 2010 has shown no increased risk of opioid mortality. Where is cause and effect here? Large-scale studies also showed that risk of abuse or chronic prescribing among surgical patients prescribed opioids is 0.6% or less. Yet prevailing public policy seeks to save this small minority by restricting pain treatment to 99.4% of patients. Where is the justice in that? You need to be guided by a quote from Dr. Nora Volkow, who addressed the task force in May. She says, unlike tolerance and physical dependence, addiction is not a predictable result of opioid prescribing. Addiction occurs only in a small percentage of persons who are exposed to opioids. Even among those with pre-existing vulnerabilities, older medical texts and several versions of the Diagnostics and Statistical Manual of Mental Disorders, or DSM, either overemphasize the role of tolerance and physical dependence in the definition of addiction or equated these processes. However, more recent studies have shown that the molecular mechanisms underlying addiction are distinct from those responsible for tolerance and physical dependence.
So I'm sorry, we're going to have
I've got two sentences here. From this background, I urge the task force not to further restrict availability of opioid analgesic therapy to people in agony. The medical evidence does not support such action. Thank you.
Thank you. Dr. Twillman, Dr. Kino, and Stefan Streck. Stefan.
I was going to be speaking for Twillman, but instead I'm actually going to hand it out to you. And Dr. Chino did not, he had to leave, so I just have a couple of questions, if that's okay. Because there was supposed to be a Q&A thing, and that's gone, but I'm wondering, do you all agree that opioids should be taken off as a treatment? Are you all in agreement that opioids should be discontinued by patients? Yes or no?
You gotta qualify that. Are you,
Do you,
for what patients?
for Medicaid patients that are chronic pain patients that are currently on medication, the ones that you've been referring to tapering to zero, are you all in agreement that they should be off opioid medications?
So I think I clarified at the beginning of the testimony, that's not actually the question at hand here. The question
That's the question that I have. Do you, yes or no, do you feel that opioids should be not used for chronic pain? You guys can't answer that? You really don't want to
But
answer
if you're
that?
asking a question saying, do you all, and there's
Okay,
X
do you,
people.
sir, do
Do
you
I?
believe that opioids should be stopped being used?
I do.
And do
Yeah.
you believe
Can
that as
can I
well?
finish the question though? Okay, so here's the question. This comes back to the pain part. It isn't a question of timing anymore, chronic versus acute, is what is involved in contributing to somebody's pain. When you look at how pain is constructed, where opioids work best is for pain that has a primary peripheral component. We have tissue-based nociceptors present. That is where opioids work well. For chronic non-cancer pain that has been there for months and years, in general situations, that is not a large component that is involved in that. That peripheral primary nociceptive component is not there. I'm sorry, I'm using the time up there. For in that situation, it doesn't make sense.
Okay, and your name is, I'm sorry, at the table?
Who's asking me?
Stefan Streck.
Okay.
Go ahead.
My 3 minutes now?
A minute and a half?
Minute and a half.
Yeah, there is no 3 minutes.
All right, so I was just in Amsterdam for 2 weeks at the start of the summer. They already have the solution that you're looking for. Since the 70s, heroin addicts in the Netherlands can subscribe to a program where they're given heroin by the government 3 times a day. Since then, their addiction population has dropped basically to zero. if you're looking for a solution, this panel should be dissolved, aim towards legalizing heroin, and leave patients who get a regulated dosage of their painkillers alone. What you're doing is cruel and unusual punishment to tell a war veteran who's had their legs blown off by an IED that they have to do yoga instead of getting an effective medication. It's also robbery of the taxpayers by saying that medication which costs hundreds of dollars, like Suboxone, or something with incredibly addictive properties like gabapentin, is a substitute for cheap and effective medications such as Vicodin. What you're doing is ignorant, what you're doing is arrogant, and above all, what you're doing is cruel and unusual, and it's wrong. If you want to be compassionate, find the solution. I've pointed out the solution. Legalize it. People don't want to be addicts. They don't want to have to show up to a government office 3 times a day to get heroin. Over time, over the past 40 years, 50 years, the average heroin addict age in the Netherlands has gone from about 30 to about 70, because all of these people have aged into the population. They have solved their problem, and if you want to solve the problem here in Oregon, follow their lead. Thank you.
Kira McGee, Kelly Howard, and Dr. Tricia Wong.
I'm going to stand because these chairs are really uncomfortable on someone with chronic pain. Are you guys ready? Okay. Hi, my name is Kara McGee. I'm 29 years old. I was born with Ehlers-Danlos syndrome type 6. It's a connective tissue and muscle disorder. I've had 36 spinal surgeries due to severe scoliosis and use a wheelchair for long distance only. I suffer from pain daily in a way I cannot describe to those who have not experienced my illness. Opioid pain medication has been the only thing that has helped alleviate some fraction of that pain. Due to my condition, physical therapy makes my pain worse. An alternative non-opioid medication either does nothing or causes me to sleep for days on end. I am a chronic pain patient and also a recovering addict. My medication was taken away from me because I overdosed when I felt like I couldn't talk to my doctor about dosage, and I was taking due to feeling judged for a problem I hadn't had in 7 years. I was 7 years sober. I had been able to reduce the use of my wheelchair. I was able to have a part-time job, do normal social activities with a good group of friends. I had hope I could live a normal life and have a job, relationships, and someday a family. That was all taken away from me when I lost my medication, and now I can hardly get out of bed. I have to use my wheelchair more than I ever had in my life. Addiction is a disease. As with other afflictions, it is not something I chose to live with. Unlike other conditions, through struggling with addiction causes my doctors to treat me as though I'm a criminal instead of with the compassion and trust I deserve. No one should have to suffer, whether they are labeled as an addict or not. I'm not advocating for an active drug user to have free access to anything they want. However, people who are willing to communicate openly and honestly with their doctor, who are making an effort to remain sober, should be given the same treatment as any other patient. In the case of a relapse, restrictions may be needed to get back on the right track, but cutting off medication completely and permanently shouldn't ever be an option for a chronic pain patient. I have been suicidal feelings since I've been taken off my medication. I've been crying up here, listening to you people, because I feel like if something doesn't change, I will not survive. And I want to live. I've been sober for 7 years because I don't want to die. But I also know which of my demons I can handle and which I can't. I can fight addiction. I cannot lay in bed for the rest of my life. Thank you.
Thank you. Carrie Hagelin.